Got it. And I know that you have extensive training in airway management as well, with your background in pulmonary critical care. How do you approach airway management? Say you have to intubate this patient with a massive or some massive PE. What's your approach, and do you ever induce? How do you do it?
Well, first of all, I like that you said if you have to intubate the patient. Because number one, decide, do I have to intubate this patient, right? So if you're thinking about intubating the patient, first of all, you should also be thinking about, do I need to give lytics? Do I need to take this person for surgical embolectomy? You're thinking about all the other stuff you need to do to get rid of the clot, right? Intubating the patient is not going to get rid of the clot. So you have to ask yourself, should I be doing that other stuff? Should I be doing that other stuff first? Do I need to intubate the patient in order to stabilize them to the point of doing the other stuff? And if you have to intubate the patient, and sometimes you do, there are ways to do it safely and there are ways to really screw it up. So first of all, you got to ask yourself, do they have to be intubated this second? Or do I kind of have minutes? Do I have time? Do I have a little bit of time or enough time to prepare for things? And if you have time on the order of minutes, I think a very safe way to intubate one of these patients would be an awake bronchoscopic intubation. Actually, Mae West is really fantastically expert at this particular approach. But you can take these patients, you can avoid the sedatives, you can avoid the blood pressure drop, you can avoid the hemodynamic effects of pushing a paralytic. You can intubate them while they're still negatively pressure breathing. And that's transition from negative pressure breathing to positive pressure breathing can be sort of a slower, more gradual transition. The hemodynamics tend to tolerate that better. All right, but that takes time. If the patient's decompensating in front of you, I still think it's an RSI approach. I think you get all the tools that in your hands are going to lead to you being able to intubate that patient the fastest and the most reliably. So that may be video laryngoscopy, that may mean a bougie. That means whatever tricks you're good at, this is the time to use all of your tools and all of your tricks. Pick a sedative that's hemodynamically neutral. I like etomidate. People like to be all down on etomidate, but etomidate is still, I think, up there in terms of what I would pick for a sedative. Ketamine is probably another good option. Please don't use propofol. Please be very cautious about using things like fentanyl and Versed and other things that may drop your blood pressure. I can almost hear the cardiac anesthesiologist or the other people listening to this right now and saying, well, what do you mean? It's totally fine to use those drugs as long as you give another medication that's going to balance out the hypotension, like giving a push of neosynephrine or something like that. And that's fine. If you do this all the time and you feel like you can balance that out well, sure. I would say, why take the risk? Use etomidate, use ketamine. I would say, again, use a paralytic. Get the patient intubated quickly. Be mindful that after you intubate them, that you don't want to use excessively high tidal volumes, because if you overstretch the lung or if you use excessive tidal volumes or excessive PEEP, you can make the pulmonary vascular resistance go up even further. So use moderate tidal volumes, titrate to normoxia and titrate to normocapnia. This is one of those critical care situations where you actually do want normalcy as much as you can, because you want to improve the PVR. And the bottom line is, you probably want to push either a vasoconstrictor, or actually I prefer like an inoconstrictor like epinephrine, as you're intubating the patient, even if they're not hypotensive. So give 5 to 10 mics of epinephrine in a small IV push right as you're about to intubate them. You're preempting that hemodynamic collapse. So again, it's a cardio-neutral sedative. It's pick the strategy that is going to lead to the fastest, most likelihood of getting them intubated quickly. Push a bit of an inotrip. I would say push a little bit of epinephrine. It's probably okay to push a little phenylephrine too. It's probably okay to start a levofed drip, but do something like that before or as you're intubating the patient, rather. And then be careful how you're ventilating them after you intubate them. Look, if you do all that stuff, you will be able to successfully intubate some of these PE patients without them crashing. But just recognize also, if you do all that stuff, there will still be patients that will still have cardiac arrest when you induce them, no matter everything you do. So be ready. Call your team in, say, I'm intubating this patient. There's a good likelihood they're going to have cardiac arrest. Get your hands ready, get ready to do chest compressions, pull the code card up to the bedside, have everything ready to go. Let's not wait to the disaster and try to dig ourselves out of it once it's there.
That's a great point, great point. And I noticed that you mentioned norepinephrine, epinephrine, phenylephrine, so it sounds like you're choosing vasoactive drugs rather than fluid loading a sick RV.
Oh, that's a very important point, yes. I would say you're probably safe in just about never giving fluids to these patients, period. I mean, just make it easy, right? So, I mean, rather than getting all complicated about how many patients might respond to small boluses, bottom line, if they're that sick and you're RV sick, don't even bother with the fluids. And I sort of apologize for giving so many different options, epinephrine, norepinephrine, neosynephrine. I guess I do that because a lot of people have their own sort of prejudices about what they think is the best drug. So I would just say you got to give something to keep the blood pressure up, and you can have a little bit of a choice there when you do it.
Great, well that's great.